Well, first, I just want to say that I had two amazing co-authors on this review paper, Geely Ahmed Toby and Omar Alani. So I want to thank them. Geely has matched in dermatology, and Omar is a final year medical student looking to match next year in dermatology. And they played a huge role in working with me to write this review paper focused on the bispecific and trispecific antibody landscape in dermatology, particularly for the treatment of atopic dermatitis. And I felt that this was a much needed topic to cover because the innovation in atopic dermatitis is exploding. And in particularly, there's a lot of innovation around multi-targeted agents, these bi and trispecifics. And so why is there a need for these? Well, it really stems from the underlying heterogeneity of atopic dermatitis. We've learned over the last several years that atopic dermatitis is really driven by multiple cytokines. You may think that it's just IL-4 or IL-13, but we've learned that itch is driven in large part by IL-31. We also have TSLP, interferon gamma, IL-22, and even IL-17A and F that all play a role in driving some of the different endotypes of atopic dermatitis. And when we have patients that are not meeting optimal treatment targets or minimal disease activity, which is really where we are striving to go with our clinical treatment of atopic dermatitis patients, the question we have to ask was, well, what medicines can do a better job than our current mono-targeted biologics? When we think about mono-targeted biologics, it means that they target one protein. Now, this could be a cytokine or a receptor. In the case of dupilumab, it is still mono-targeted, even though it does reduce signaling from IL-4 and IL-13 because it's targeting IL-4 receptor alpha, a single target. We also have tralokinumab, lebrikizumab that are targeting IL-13 cytokine, a single target, and nemolizumab targeting IL-31 receptor, again, a single target. What the innovation in the bi and trispecific space is trying to do is say we know that our patients with atopic dermatitis have this underlying, not only the clinical heterogeneity, but an underlying molecular heterogeneity. How do we combine, how do we target antibodies to hit two or three different cytokine pathways as opposed to one or two in order to be able to get more complete, deep, and sustained responses of not only skin clearance, but also itch relief and other symptom relief in our atopic dermatitis patients. So that's sort of the rationale behind why these molecules are here. And there's a whole slew of innovation off this concept. And what I mean by that, what we cover in our review paper is not only the different, up to 20 different bi and trispecifics in development, but also what are some of the engineering advances that are being incorporated into those bi and trispecifics. Some of the engineering advances that we're seeing in these bi and trispecifics involve the half-life extension technologies that are being incorporated in with the goal of trying to get to Q3-month or Q6-month dosing for our patients, which would be really revolutionary for atopic dermatitis patients. There's also other technologies, such as engineering the FC portion of the antibody so that it either has or doesn't have certain properties, such as antibody-dependent cellular cytotoxicity. We've seen that more in the OX40, OX40 ligand pathway drugs that have been developed to date, that's been an issue. But under engineering the FC portion of the antibody is important. We also talk about the different, not just cytokines that drive the heterogeneity, but chemokines that drive a lot of the heterogeneity in atopic dermatitis. And together, our goal was to paint a picture of where are the limitations currently. The limitations come from this breadth of underlying molecular drivers of AD, both on the cytokine and chemokine side, and the need for improving upon mono-targeted biologics to multi-targeted biologics in order to more comprehensively help patients hit optimal treatment targets, both in the skin and patient-reported outcomes like itch or like sleep. And ultimately, the goal is to, in the end, help the patient achieve better disease control, more durable and long-lasting disease control, but also do it in a safe way. As part of this intervention, can we cut back on things like conjunctivitis risk? Some of the emerging concepts that have come out in the last couple of years have really focused on where the receptors for a lot of the cytokines driving AD exist. We know that they exist on keratinocytes. We know that they can exist on some immune cells, but they also exist on sensory neurons, such as IL-4 receptor alpha, IL-13 receptor alpha 1, as well as IL-31 receptor. And what we've been learning is that these cytokines modulate these neurons. They modulate the itch response. And part of the intersection between different inflammatory and neuroimmune pathways is really, in order to control atopic dermatitis, you really have to control both angles of the skin inflammation and the drivers of itch sensation. And that is where the multi-targeted biologics are trying to find the right combination to optimize skin relief, but also can we control the itch responses in these sensory neurons? And for example, that's why a number of the bi and trispecifics are trying to target either IL-31 cytokine or IL-31 receptor, or trying to target TSLP in order to try to control that itch component that patients really suffer with atopic dermatitis.